With me are my colleagues, Dr. Raju, who's a senior cardiologist and my colleague, and we have Dr. Shrikant Dyaram, who is also my colleague, and then we have Mahesh, our staff nurse, and Srinivas, our cath lab technician, who will be assisting with this case. So before we go ahead and start the case, I would ask Dr. Shrikant to present the case.
Today, we have a 83-year-old man who's a diabetic and a dyslipidemia. He presented to us with angina on exertion. His echo was normal. This was in 2022 and he underwent an angiogram. Next slide. Next slide. So, this is the angiogram in April 2022. You can see there he had a very significant severe ostial LAD stenosis. LAD was calcific. It's a left dominant system, as you can clearly see there. This diffuse disease of the LPDA and there is severe stenosis of the mid LAD and diffuse disease of the distal LAD. This was the situation in April 2022. He was advised intervention then, but he denied and he was on medical management. Next one. So these are the caudal views. Again, you can see that the left main is relatively disease free here. There is the proximal circumflex looks okay. There is severe stenosis in the LPDA and severe stenosis of the ostial LAD. So he now presented again with refractory rest angina on
So the images shown were 2 years back angios. Now we're going to show the present.
Multiple antianginals. Echo still shows normal LV function, and he underwent an angiogram a couple of days ago, and this is what it shows. You can see there the left main disease has significantly progressed. Now there is severe left main stenosis. The LAD is severely calcific with almost occluded LAD in the ostium. There is a trickle flow antegradely, and the disease in the mid LAD and distal LAD also looks progressed. The LPDA looks similar with severe stenosis. So this is next slide. This is what this is where we are standing today, and these are the caudal views. Yeah, so he has a left dominant system, RCA being very small. So
I'll pause here and take the opinion of the panel. So this is a case, and the surgeon was not very keen on taking up this case, obviously, because this is an LAD which is not graftable. 84-year-old guy, frail person. So it's a surgical turn down, and the PCI is the only option. Refractory angina. So here I would like to discuss a few things. One, what's the strategy of PCI for this patient? I would like to take the opinion of the panel. One, in a case like this, where there is a left main tight stenosis, ostial LAD tight stenosis, there is a diffuse disease distally. LV function is normal, but it's a left dominant system. Patient has recurrent angina, and during anginal episodes he was going into hypertension. So is there a role for mechanical circulatory support upfront, or should we reserve it for during the procedure if the patient has a problem? If you're looking at a mechanical support, which kind of support are we looking at? Should we look at Impella or ECMO or just plain simple IABP? So what's the opinion of the panel? Shashi, what do you feel? Yeah. So first we'll go stepwise. Let's generate some discussion. Yeah. So we'll come to the strategy later. First, do you think there is a need for mechanical circulatory support in this patient? So would you like to put something or just go ahead and do it?
No, I would like to do the end-diastolic pressure, look at the EDP with the pigtail, look at the end-diastolic pressure, would he tolerate, if he has a high end-diastolic pressure, probably I would think of using a mechanical support in the form of an IABP initially.
Dr. Thomas, what do you feel? Yeah, okay.
Yeah.
Can you just go back to that right injection? Is there retrograde filling of the LAD there?
No, not much.
The next shot. Yeah, this one.
left dominant system.
Yeah, but the right is
RCA being very small. So this is a patient now. So he was sent for surgeon's opinion.
So this is one aspect which we can discuss, whether we should put a mechanical circulatory support up front or not. And second thing is, if you're going to go and do some form of calcium modification, which device would you prefer? Rotablation, orbital atherectomy, or intravascular lithotripsy, or is it a combination of all these? What's the choice of the panel if you have to do this case?
So my approach for this case would be, I would first do an end diastolic pressure, look at the EDP, and the LV function you said is good.
LV function is okay.
Is good. So I would not jump straight away to Impella. Probably I would, if the EDP is high, probably I would put him on an intra-aortic balloon pump on the table, and with a good LV function, I think he would tolerate a procedure there. And ECMO, I would not go much on that immediately. As far as the imaging choice is concerned, probably he's 83 years old. I think he would have some renal dysfunction, so I would still think IVUS is a good choice.
So renal function is okay for this patient.
In spite of that, with 83 years, I think his renal function would be borderline, and probably I would go for an IVUS rather than an OCT. I know there's a lot of calcium there. I would still go with an IVUS. I would do a calcium modification, at least the ostium of the LAD probably with a rota. And if I don't crack it with a balloon, the cutting balloon or a high pressure balloon, then I would think of an IVL as an add-on choice because of the cost issues. Once I dilate the LAD and have a good result at the ostium of the LAD, I would probably do a DEB for the distal LAD and then put a stent from the left main across into the LAD and then take it from there.
Yeah, okay.
Dr. Alexander, your approach, sir?
There is a distal circumflex lesion also, and we need to decide whether we need to tackle that, in which case we will need to do that before we maybe even before we tackle we stent the left main into the LADs. But otherwise, I think, yeah, I would also agree with you. I wouldn't put in a support system, but I would have access from the other side kept while I'm planning this procedure.
Okay, so let's go ahead and I'll show you what we did actually.
And in view of high risk surgery was turned down.
So this is an interesting case, and there are several aspects which we can discuss in this patient, and several decisions to be taken while treating this patient. The first decision is regarding bypass surgery versus PCI. He is an 84-year-old man, a frail person, densely calcific vessels, not so good targets. He was seen by the surgeons, and they felt that this is not a good case for surgery, and they've turned him down. So we have no option but to take him up for a PCI in view of refractory symptoms, which he has refractory rest angina. So the other issue is, like, what's the strategy for the PCI for this patient? I think as we do the case, let's go ahead and discuss these things. Now, this patient had a normal LV function, but he has a very tight left main and a ostial LAD lesion, very diffuse disease in the LAD. And in case if we go ahead and do either a rota, we may end up with a no flow and that can result in a hemodynamic collapse. So in this kind of a situation, one point of discussion is whether we should put mechanical circulatory support upfront or do it as and when required. That's one point which we can discuss. And if it is a mechanical circulatory support, should we consider Impella or should we look at an ECMO or other alternatives like IABP? So we thought that his LV function is okay, and there are financial issues in terms of going ahead with Impella. So we have put ECMO as a backup. In case if there is any hemodynamic collapse in the cath lab, we have ECMO which is primed and it is ready for a backup. Regarding the strategy for PCI, obviously we need to do debulking, calcium modification devices need to be used in this particular patient. So it's rota versus doing a intravascular lithotripsy. These are the two options. But if you look at the angio, I'll show you once we go through the runs. We have a very tight ostial left main and calcified calcific and very tight ostial LAD lesions. So we can't get an IVL balloon in unless we predilate. And if we predilate and we have a bad dissection there and the lesion was unyielding, then it will be difficult to get the rota through. So I think our strategy upfront would be, one, to wire the left main and the LED, go ahead and do rota for this patient, get the imaging down, assess the lesion, and then take a call about how to proceed further.
Dr.
For
Ramesh,
both the
can I
ostial
pause
and
you?
LMCA as well as the distal disease.
Yeah.
So with this introduction, let's go ahead.
Yes.
Thank you. So, my question to you and to the audience too.
Yeah.
Of course, large vessels, would you go with the standard size rotabur or 1.5, or do you go with the 2.0
We'll
straight away?
discuss it as we go through. Yeah.
Okay, that's
See,
good.
there are 2 points here.
Yeah.
One, if you're going to do rota, from where to where in this vessel you're going to do rota? Is it just going to be the left main and the osteoproximal LED? Or if you see the previous angios 2 years back, you can see the diffuse calcific disease all through the distal LED. Whether you want to take the rotabar down all the way down.
No.
So taking the rotabar down all the way down will result in a no flow because you don't have a good distal runoff. So in this particular case, we thought that we should rota the left main and the osteoproximal LED.
Right.
So, and then decide subsequently, okay? So if you're looking at the left main and the osteoproximal LED, if you look at the left main and osteoproximal LED, these are all large size vessels. So you have to choose, but then at the same time the LED ostium is very, very tight. So you have to choose between 1.25 to 1.5. It's easy to cross with a 1.25, but burr entrapments and all these are more common. And if you can get a 1.5 burr, that will be the right thing to do because that will be the appropriate size burr. Only thing is we run the risk of that we may not be able to cross it. Actually, I'll show you when we are doing what difficulty we face. So in this particular case, we chose a 1.5 burr.
So we have taken bilateral femoral axes, both arterial as well as venous. And the reason for that is while we work on through one arterial axis, this is a backup axis for ECMO in case if there is any crash of the patient. So we went in from the femoral approach with a 7 French guiding catheter, XP3. If you can see, I've placed it just at the ostium of the left main.
So this is one point I want to discuss. What type of guiding catheter, what kind of guide wire, and what would be the strategy? What would you like to do in a case like this?
No, I would take an active guide support, even if it's ostial left main. You can play with it, I can move it because the distal vessel is really calcified. It's difficult to push things down if you don't take an active guiding support. My standard workhorse wire would be run through wire and
so would you like to cross directly with the rota wire or would you like to?
No, my strategy would be to use a run through wire over a micro catheter, push it down and then exchange it with a rotafloppy wire because there have been instances of the wire breakage with the rota wire if you use it directly. So micro catheter preloaded for the first time, go through the distal LED, exchange it with a rotafloppy wire and then.
Yeah, so precisely we chose an XP3 basically we thought we need a support although it's an ostial LMCA.
Yeah.
Plain Judkins will not give you enough support
Absolutely.
to do this
would
case.
not be able to.
And I'll show you what we did.
Can you please show the current runs, please? Yeah, you can see that's the caudal view and it's almost subtotal occlusion of the ostial LED plus, seen plus. You can see the subtotal occlusion at the ostium of the LED, very densely calcified. And that's the cranial view where you can best appreciate the disease in the left main with dense calcification. It's a little tricky origin of the LED. It's not a straight course. There is a little bit of tortuosity there. So we thought that it will be difficult to cross with the rota wire directly. So we thought that we'll first cross it with a regular wire and with a microcatheter help and then exchange it to the rota wire. So we tried going in with a pilot wire. You can see with the microcatheter support, you can see the wire, it was very difficult to wire that LED. You can see the bend there is significant. So we changed the wire to Fielder XT and with the help of a Fielder XT, we were able to cross this LED. Now then we tried to cross with the microcatheter, but unfortunately we are not able to. You can see the guide backing off and we couldn't cross the ostium of the LED with microcatheter.
So what do you like to do now? So we crossed the
I take
the
a low
wire,
profile balloon.
but our microcatheter wasn't going.
We take a low profile balloon, 1, 10 or 0.75, 10 and then dilate it a little bit to get the microcatheter down. It's difficult to put a rotawire down this way directly. Or even just jam the microcatheter at the ostium of the LED, and you can sometimes push in the rotawire down.
Yeah. So these are the options. Like,
Yeah.
so what we did is we took a 0.7 millimeter balloon.
So then that's a dilemma. Now what to do? So what we did next was we thought we'll take a 0.7 millimeter balloon, try if we can dilate it, and fortunately the 0.7 millimeter balloon crossed that ostium of the LED, and then we went up to 20 atmospheres. Ostial part of the LED is dilated. We couldn't get the balloon any further down because of the calcium it's obstructing. Now this time, after this dilatation, we were able to get the microcatheter down. You can see that on the screen. And we exchanged it with the rotawire. And subsequently, we have taken a 1.5 Rotalink Plus and we rotablated it. And you can see there is a lot of difficulty at the level of crossing the ostium of.
So this is a problem with the 1.5 burr, very tight lesion. We had a difficulty in crossing initially. 1.25 would have crossed easily, but it would have been undersized burr 1, and sometimes burr entrapments are more common with a smaller burr.
The LED. Finally, we could cross that and rotablate it up to the proximal LED. So these are the multiple runs with the rota. Yeah. And this is the shot after doing the rotablation. You can see the flow coming up in the LED. The distal part of the LED is pretty diffusely diseased. We have the rotawire there. So this is where we are. So at this point of time, I think that we will exchange this rotawire with a regular wire and do an imaging to assess the left main and the LED and take things forward. We could only get it up to somewhere around the mid LED because of the distal diffuse disease and calcium, and we took an OCT run. If you can notice here, because after the rotablation, the ostium of.
So one point, OCT versus IVUS, you can debate it either way. When you have an ostial left main disease, large vessels like this, so maybe IVUS might have some advantages, but the calcium morphology and the calcium the morphology can be better seen on an OCT. So since for academic purposes, we thought that we'll go in with a OCT, but if somebody chooses to go with IVUS, it's fine. Okay.
The LMCA looked pretty well shaped, and we could get the guiding catheter in to the left main. Earlier it was damping when we get the guiding catheter up to the ostium, but here we could get the guiding catheter in, and then we took a.
Yeah, that's another point. After the rotablation, we could get the guiding pretty much into the LED, engage it better.
Srikanth will present the findings.
So, what are we seeing on the OCT run? So this is the distal part of the run where you can see that you can move the OCT images frame by frame. So there is significant calcium all along the vessel. So this is the distal part of the lesion which you can see there, and keep moving. So the lumen areas here, if you look at the lumen areas for around all along were anywhere from 4 to 1.5. So basically, it is a densely calcific lesion, fibrocalcific areas with areas of concentric calcium, and there are interspersed nodular calcium there. You can see a small calcific nodule there, and if you can move the run proximally, yeah, there is a significant big calcific nodule there. Keep moving, and there is area of significant concentric calcium all along this almost 360-degree calcium, and in the other areas there is significant fibrous block. Keep moving. Significant eccentric calcium again. The lumen areas are okay here. We are coming to the proximal part of the LED, and that's the ostial LED. You can see there significant calcific, very tight stenosis there, calcific, fibrocalcific lesion. And you can see the dissections which are caused probably with rota and balloons there. And then keep moving. And this is the keep moving. And we are coming to the into the left main. This is the distal part of the left main. So what was interesting was distal part of the left main, the lumen areas were good. When we come to the proximal part of the left main, there is a significant big nodular calcium in the ostial left main, which you can see there. So here, if you look at the lumen areas are less than 6, but they're more than 4. So we are just trying to debate what to do for this nodular calcium in the left main. So this is where we are standing now.
So what we did next is, as you can see on the screen, we used an IVL balloon, a 3 millimeter balloon.
So after the rota, still very dense calcium. So we thought that we should use an intravascular lithotripsy to get a better result.
Yeah,
And
I think my approach would be the
didn't
same.
present the whole this thing. The thickness of the calcium more than 1000 microns, 15 millimeters length of calcium, and circumferential in many. You can see all calcium morphologies in this lesion.
C2 plus, and we went ahead and delivered multiple pulses in the mid and the proximal LAD, including the ostium. Next. So there was not much waste distally, but somewhere in the middle, seen plus. Yeah, so there was some waste in the middle, but with multiple pulses, this has given way. So we dilated the ostium also with the IVL, and subsequently we took a 4 millimeter IVL for the left main as well as the ostium of the LAD. So this is after the dilatation with the 3 millimeter IVL. Yeah, this is a 4 millimeter IVL. We gave multiple pulses at the ostium of the LAD as well as the left main. So that's it. So this the ostium of the LAD has yielded better after this 4 millimeter. And
so the important thing is when you're occluding the left main with IVL, you can't give the full 10 pulses because patient was developing hypotension.
Exactly.
So you have to break the pulses.
Yeah.
So
This is the place where you would get a benefit
This is
with
the
an
left main.
impella.
Yeah.
This is the place where you get better with an ECMO rather than with an IABP. And here you have not electively put an IABP beforehand.
No.
Yeah.
So
It's
when we
usually
reduce
they
the number
tolerate it if the impulses are not completely given.
we gave 5 impulses
Yeah,
a go,
that-
and he was
that-
able to
that would
tolerate
be a
that
good
much.
strategy.
The moment we go to 10, he's developing hypertension.
part, you can see there's not much waste actually. So not much waste in the left main. So we gave multiple pulses in the left main also. Subsequently, this is the run, what we got there. So the next thing what we thought is before we go ahead and address the
So what's the strategy for the
Circ.
distal LAD? So we have addressed the LMCA and the proximal LAD.
Probably
So
like-
you can see the diffuse disease in the distal LAD. So what would you like to do in this case?
Like Dr. Thomas has said, probably I would deal with the circumflex first.
Yeah.
Reassess the LAD. Probably distal LAD for an 83-year-old man, I would just feel it, leave it alone. Rather than-
It's a significant territory.
I know, but
Yeah. Anyway,
most
I'll show you what we did. We went with your first strategy. Anyway, I'll show
left
you.
main and the proximal LAD. We thought we should optimize the
I
result
feel
in
you should not touch
the
it.
mid to distal LAD. So we used a 2 millimeter balloon and
you did it.
did multiple inflations there.
Boba.
So now with that we could get the IVL catheter, OCT catheter little more further down, and then we did a OCT run.
This is after
Srikanth will now
post-IVL.
show you the OCT findings.
So what we are seeing on the posterior run after multiple dilatations is that at the beginning of the run you can see a small dissection which is over 3 frames. Yeah, significant dissection, but it is a small result there. The result looks around 2 mm, 2.25 mm there. And then if you come little proximal, you can see that we have caused multiple fractures in the calcium. So whatever we have done, IVL and balloons has worked well, and I can see multiple fractures there. And if you come a little more proximally, we have got good lumen areas now all along, and multiple fractures again you can see there in the calcium again. So it clearly shows that we have done prepared the vessel adequately. So if you come a little more proximally, keep moving proximally. Yes, and go a little distal, please. You can see what we have done to the calcific nodule there. There is some eccentric calcium there. We have not caused much damage to the calcium, but you can see that there is a big dissection by the side of it. We are hoping that it will give good expansion of the stent, even though it might be a little asymmetric. So if you come a little more proximally, move proximally. Yeah, some more proximally. Yes. So again, we are seeing that some dissections at proximally. That is again some eccentric nodular calcium there. But the vessel is well prepared, beyond the nodule. And this, we are coming to the proximal LAD now. Keep moving proximally. There's a lot of blood flow there, but the whatever we are seeing, the lumen areas, they look good. Some dissections there again. We are coming to the ostium of the LAD now. So ostium of the LAD now, you can see that we are good. We achieved good lumen now, and good dissection there. So this vessel looks that it's well prepared and ready to take a stent now. So coming to the left main, there's some blood swell there, and this we couldn't see the how what happened to the nodule there. We are not able to see it clearly, but anyhow, seeing the balloon how it expanded and all, we are planning to stent it now.
Yeah, the good thing is with the IVL balloon, we could get a good expansion. The balloon was expanding well, and there was no significant residual on the IVL. So with that, what we thought is for the distal part, we will optimize by doing a drug-eluting balloon, take a 2 millimeter drug-eluting balloon and dilate it distally, and then go ahead and address the proximal part, that's the mid to proximal LAD as well as the left main. So that's the plan now.
So that's the 2 millimeter, 2 into 36 millimeter drug-eluting balloon, and you can see a fairly okay result somewhere in the mid to distal LAD. We thought the distal vessel is too small, and
so after the IVL, based on the OCT, we found that somewhere around the mid LAD, just after that small septal and diagonal, that's a good landing zone. So we went ahead and put a 3 into 23 millimeter Zine Sierra there. Yeah, you can see there's no waste there. The stent looks quite well expanded. Okay, so you can see the stent quite well expanded. So we've taken a 3.5 into 33 millimeter Zine Sierra. We placed it at the ostium, and that's the positioning of the stent with a minimal overlap into the proximal edge of the distal stent. So we checked the position of the stent in different views, and it looked okay. It's 1 millimeter protrusion into the aorta, and subsequently we did a pod to the left main part with a 5 into 8 millimeter balloon. We went up to around 12 atmospheres. That comes to around 5.1, 5.2. So that's for the deployment of the stent. Now at this point of time, we could see some pinching of the sarcostium, so we thought that we should do a kissing balloon dilatation. So when we pulled the LAD wire out and wanted to put it into the circ, unfortunately the wire is coming to the guiding, so we had to recross again. So we could recross that, and subsequently the circumflex wire was taken out and put into the LAD. Now at this point of time, wire rewiring, there was an issue with the proximal edge of the stent. You could see that there is a stent distortion at the proximal edge, and we had a problem in getting the balloon through. So we got an OCT done. We could get the an OCT catheter through, and we did that OCT. So we found that in the initial few struts, both the wires were going through the distorted stent, and it was causing through the stent struts. So there was distortion of the stent.
We are looking at the OCT runs now. So this is when we had some difficulty with the left main stent. So we were wondering that when we pulled out the circumflex wire and then the wire, we were trying to wire the circumflex, this probably passed through the proximal stent struts, left main stent struts, and then crossed into the circumflex. The guide probably distorted the left main stent, mainly the portion outside the left main ostium, which is in the aorta. So this is the OCT run. Now we'll see it from the. Can you play the OCT from the LAD into the left main, from distal to proximal? Yeah. Yes, that's us. Now can you just go to a little distally? Yeah, some more distally into the LAD. So this is the, yeah, it was not a good run. There's a lot of blood swell, mainly because, the catheter, we didn't want to engage it aggressively, and it was not going into the stent. So you can see that the proximal LAD stent looks reasonably expanded, opposed, good lumen areas there. If you see the images proximally, now we are seeing we are coming into the left main now. So you can see the blood swell. And the distal part of the LM stent looks okay, and I want you to stop there. So and move it slowly. So you can see there, you can see when the imaging element is coming to the aorta ostium, you can see few distorted stent struts. Actually, it's little difficult to understand because of the blood swell mixing with the stent struts. So what exactly happened was, the part of the stent which is near the aorta, LM ostium, it got distorted. The wire probably went through the stent truss there into the LM. So the distal part of the LM stent is okay. The proximal part is crushed like this. This is what, next we try to work that area, that stent strut as our
just
true
pause
lumen
for
from
a
then
second.
onwards, and then we created,
Yeah.
So did you do a pot of the left main before you tried to rewire the circumflex?
Yes, yes. We did a pot with a 5 millimeter balloon.
Okay.
Yeah. So I think subsequently when we are trying to recross, that's when the guiding catheter has hit the stent struts at the ostium and deformed the stent.
a path through that, and then we put in the stent there.
Stuff, yeah.
So this is, these are the IVUS pictures which we are seeing. And so because we are not able to get good clearance with OCT, we tried an IVUS basically to understand what's exactly happening. This is the LED all looks good. I'm just pulling the catheter to the left main part. That's the subcostume. And then in the distal left main, you can see one layer of stent. Stent is well expanded, mild asymmetry there, but is well expanded and opposed. And then you can see that there's something funny happening here after this. Yeah, so this part, you can see the crushed stents here and the other layer of stents here. So that's what we found, and we got to the same conclusion on both OCT and IVUS.
We thought that the LED.
So I would like to pause here. I don't know whether, just want to. See, basically this is a problem when you use a 7 French guiding catheter and then you're stenting an ostium of the left main. So there was distortion of the stent at the ostium. Now, the mistake which happened was when ideally we should have taken a third wire and put it into the circumflex and leave the LED wire as it is. But we tried to pull the LED wire and put it in the circumflex, and accidentally the wire came back into the guiding catheter. So when you try to recross, that's when it went through the stent struts, and this is the problem which happened. Now we have to bail this out. What is the strategy which you would be thinking about? And in the OCT it shows that it's the initial 4 millimeters of the stent which is mangled. You have you have the wire in both the LED and circumflex, both were wired, both were going through the stent struts initially, but subsequently they recrossed and they're in the proper lumen, both LED as well as circumflex.
No, I think you have no choice to take another wire and try and wire again through the stent, through the true lumen, because if you crush the stent now, I mean, you try to cross through the lumen. If you can't, you're forced to crush the stent and then put another stent in there.
As we go through, I'll show you the stent boost images. It's impossible to get into the true lumen without going through the stent struts, because this. I'll show you, once you see the images you'll understand, and then I'll show you how we bailed it out.
The wire is more in a better position. So we went ahead, we put a 2.5 balloon and then subsequently a 3.5 balloon and dilated. So then that's the 2.5 millimeter balloon, 0.5 balloon. We did boost in between. I don't think we could get a feed from there, but we'll try to show you in the auditorium, the stent boost this thing also. So we could see that the LED wire is also through the stent struts proximally and not exactly in the lumen. That's only in the initial few millimeters. And so there was distortion of the LED stent, distortion of the left main stent.
So what we actually did is we cannot get into the true lumen in the first 3-4 millimeters because the stent is badly mangled. But our wires are into the true lumen somewhere in the after the first 4 millimeters. So we went ahead, dilated sequentially, and with even a 5 millimeter balloon. So the struts were opened up properly. Then subsequently, now we have complete access. We wired the circumflex. We did a kissing balloon dilatation because from somewhere around the, after the first 4 millimeters, the stent was okay. So we optimized the result at the left main bifurcation with a kissing balloon dilatation, 3 and 3.5 millimeters. So this is what you're seeing on the screen. Then we optimized the LED with the balloon, the LED stand. So this is the result. And you can see that the struts were opened up quite well, close to the ostium. And this is the time when we thought that we should go ahead and stent that ostium and the proximal part. So the total,
So that's the positioning
yeah, you
of
can
the
see
8
there.
millimeter stent,
This is the
and you can
positioning
see
of
it's,
our
covering the
other stent.
distorted
8
stent.
millimeter stent would be
That's
quite
the
enough to
positioning
cover
from
the ostium and the proximal
We
distorted
deployed
part.
it, and it's a 4 into 8 millimeter stent deployed at 18 atmospheres. Subsequently, so we've taken a 5 into 12 millimeter balloon, and we post dilated the new stent which we have put, as well as the left main part of the old stent till just before the bifurcation. And we can see a well expanded stent on the stent boost also. So
You can see the first few millimeters distorted stent where the second stent is put, and it's well expanded now. And this is the final result we got. And I'll show you the OCT runs with this. You can see a well expanded left main proximal LAD and the proximal LAD. The distal diffuse disease, but post drug-eluting balloon, it seems quite
So this
okay.
is the final OCT run after placing another stent in the left main. So the proximal LAD all looks good, good lumen areas, good apposition, no malapposition, good expansion. And when you come proximally, so that's the circ ostium looks good. There's no disease. The distal left main is well expanded. Yeah, good lumen areas. And if you come towards the left main ostium, this is where it gets a little interesting. So you can see the stent struts there, and you can see the crust and struts on one edge, basically. So, and that's the crust part of the stent. And now, come proximal, yeah. And this is a peculiar left main, because the ostium is little oblique. So one stent is, it's hanging. If you have to cover the ostium properly, you have to pull the stent into the aorta. You must pull the stent into the aorta a little, and you can see that stent in the aorta there. So finally, we got a good result. Part of the stent is crushed. The 2 layers of the stent in the left main, and rest of the stents look okay.
These are the final angiographic pictures. I'll show you all the views. So this is where we stopped. We thought that the distal, the circ disease, the LPDA, we can address later if it is required medically. 84-year-old guy. So if we get this much, I thought it's okay. We can medically manage the LPDA. So these are the final pictures.